Hello, and welcome to an adaptive learning presentation. If dressing up was a requirement for this presentation, as far as you know, I'm wearing a suit and tie. This presentation is about hairy cell leukemia. Hairy cell leukemia is a cancer that is very close to my heart because my grandpa has had it for 40 years. 40 years ago, my grandpa was in a room with 5 other men and received the news that he had 6 months to live. Him and his neighbor in the hospital bed next to him were the only two that survived. He is one of the major reasons why I'm interested in biology and the human body. So, hairy cell leukemia under a microscope already creates some concern for observers. It is described by some scientists as a fried egg looking cell. It is a significantly darker cell in peripheral film, which is the photo on the left. Then on the right, it shows a trepene biopsy figure, which is where someone might see a fried egg in the middle right, which is the hairy cell. Hairy cell leukemia is a rare, chronic B-cell lymphoproliferative disease that is normally found in the bone marrow, spleen, and liver. What is important to note about the lymphoproliferative part is that it usually occurs in people with compromised immune systems. Hairy cell leukemia patients do normally have a struggling immune system. The white blood cells, red blood cells, and platelets are all low. This means that the body doesn't have the required white blood cells, specifically neutropenia and mitocytopenia issues, to fight off disease. The leading cause of death with hairy cell leukemia patients are infections like pneumonia and sepsis. Although rare, 1,000 people in the United States every year are diagnosed with hairy cell leukemia. There are more men than women cases, and there is not a discovered reason as to why there are more cases with men, but families have been observed in an attempt to study the genetics of hairy cell leukemia. Speaking of families, these photos indicate two family studies. The attempt of the study was to see if hairy cell leukemia could run in the family. For a rare type of disease, finding two cases where two family members developed lymphocyte cancer seems more than coincidental. This study that features these photos looked into the possibility that lymphocyte cancers had a chance of being a hereditary disease. This study didn't find complete evidence, but it could be a topic of future study to see if these cancers can be tracked through families. However, there is evidence of a consistent mutation in the BRAF-V600E gene in almost all hairy cell leukemia patients, but not other lymphoid malignancies. This discovery could lead to earlier diagnosis and treatment. If an oncologist knows to look for this gene mutation, then they can have a better idea on which treatment to use and when to initiate the first line of therapy. This BRAF V600E gene could also be the key to figuring out if lymphoid cancers are hereditary. Identifying these hairy cells sounds pretty simple. Well, you go into the lab and look under a microscope, and poof, there's a ton of obvious hairy cells all bunched together, and then doctors will know exactly what treatment to use. Unfortunately, no, that is not the case. This figure illustrates chronic lymphocyte leukemia and hairy cell leukemia in similar slides under a microscope during the study. These two lymphoid diseases are difficult to separate, as shown in the top right corner of the figure. Even though it is difficult to distinguish the two, the study of these two cells simultaneously can benefit future treatment options. If methods of chronic lymphocyte leukemia has treatment that hairy cell leukemia hasn't tried yet, and vice versa, then treatment of these lymphoid malignant diseases can be improved. Every study that I observed referenced the importance of sequential studies. Whether it was a study in 1980 or a study in 2019, every source expressed the need to continue building off previous findings because the answer to hairy cell leukemia is going to require many failures in order to succeed. The research didn't state that you need to study hairy cells only. In fact, studying other diseases that behave in a similar way can provide perspective for the improvement of care for hairy cell patients. I believe that studying chronic lymphocyte leukemia and hairy cell leukemia is a stepping stone to something greater, and there will be more studies ahead. Retroviruses is another topic of study, specifically HTLV. There are several subtypes of HDLB, but for hairy cell leukemia, HDLB2 is the most important. HDLB2 was originally found in a hairy cell leukemia patient. Weirdly enough, HDLB2 is not associated with lymphoproliferative diseases. On the other hand, this virus is compared to HDLB1 in many ways. HDLB1 is associated with diseases like adult T-cell leukemia, myelopathy, and tropical spastic paraparesis, which is interesting because there's evidence with lymphoproliferative disease in with HDLB1. HDLB1 and HDLB2 have 70% nucleotide similarity, similar genome structure, encode the structural and enzymatic proteins of a retrovirus, as well as code for proteins TAX and REX, and both have an RNA transcript. So, how can HDLV1 be so similar to HDLV2, but HDLV1 is associated with lymphoproliferative disease as HDLV2 is not? But HDLV2 was first found in a patient with lymphoproliferative disease. This study was conducted in 2019, so it is very recent and applicable for future study. This research speaks about the different receptor and binding molecules in HDLV1 and HDLV2. HDLV1 retrovirus uses heparin sulfate proteoglycan and neuropilin-1 for binding, and then uses glucose transporter 1 for entry. HDLV2 uses only neuropilin-1 for binding and glucose transporter 1 for entry. Therefore, an idea arises in my mind. If HDLV2 could be introduced to a different binding molecule, then there is a possibility that this virus could be used to treat hairy cell leukemia. Patients with HDLV2 could be given a treatment that binds to a receptor molecule using heparin sulfate proteoglycan, which then can be transported throughout the body. I think this is a lucrative opportunity for study, and I hope that someone has the same idea that I do, because that would be pretty cool. There are other receptor pathways that could inhibit the growth of hairy cell leukemia. This form of pathway is called BCR. BCR triggers various signaling pathways involving kinases such as BTK. With the constant activity from the BCR pathway, malignant tumor growth is optimal. In hairy cell leukemia patients, the BTK kinase is found to be overexpressed and therefore is a vital role that continues to grow the malignant tumors. This figure looks a lot like an essay on one of our exams, so I was immediately drawn to it. It shows where the inhibitors of BCR signaling kinases are, as well as the entire BCR pathway throughout a hairy B cell. On the right side of this figure actually shows the BRAF inhibitors, which is from the gene that was discussed earlier. The BRAF inhibitors have something to do with the BRAF V600E gene mutation that is found in most hairy cell leukemia patients. So maybe a potential treatment route is with inhibitors that attack these specific regions. Throughout all research and even this presentation, treatment has been the overall goal. When patients are being treated, the first time is called first-line therapy. The second time is second-line therapy, and so on. If a patient isn't in remission after first-line therapy, then they move into the next line of therapy. The figure to the right has 3 typical hairy cell leukemia treatments. 2-CDA is the most effective in first-line treatment and in general, while INF-alpha is second most effective and splenectomy is last. All of these treatments are over 80% effective in this study, which is great, but getting hairy cell patients into remission doesn't seem to be the biggest challenge. The biggest challenge is keeping them in remission. 40 years ago, when my grandpa was in the hospital, as soon as he was diagnosed, he had a splenectomy. This figure to the right explains that a splenectomy has the lowest remission rate, as well as the article stating that it has the highest relapse rate, even if the patient does go into remission. My grandpa has been battling this cancer for 40 years with a couple of relapses. You might be thinking, well, he has made it back into remission, right? Well, yes, and I'm thankful for that. But if you remember, Hairy cell leukemia causes a weakened immune system. Therefore, patients like my grandpa, who can't stay in remission, suffer from the possibility of constant disease. Therefore, these results are positive, but not perfect, because there is more work to do. Although relapse rates are still pretty high, there is hope. There are many different forms of treatment that are looking like possible solutions. There are receptor pathways that was spoken about earlier, like the BCR inhibiting BTK pathways. Manipulating viruses can also be a possibility with binding treatments to retroviruses to be injected into the body. There are also 4 additional drugs that are being tested to help hairy cell leukemia patients. These drugs, flavopiridol, uh, vemurafenib, rituximab, and ibrutinib were only slightly mentioned in the 2019 article. However, vemurafenib was mentioned a decent amount, along with rituximab. Rituximab was cleared by the FDA in 2018, and its purpose is to treat patients who are on their third-line therapy or later and have struggled with relapse. Vemurafenib is an oral inhibitor of BRAF serine threonine kinase. This drug still isn't where it needs to be in order to be regulated by the FDA. At this point, research for vemurafenib is attempting to find the optimal dosage for patients. There will of course be continued focus on the overexpression of CD22 and CD25 antigens. Finally, I think there needs to be a treatment that replaces the splenectomy. I think the splenectomy has the most risk, lower chance of remission, highest chance of relapse, and also requires surgery. Not every patient can be treated the same way, so maybe sometimes a splenectomy is the best option. I think the future holds a replacement for the splenectomy in the form of one of these previously mentioned possibilities. Then, people like my grandpa can not only survive cancer but also be in remission and stay in remission. I don't know about you, but I am excited for what's ahead for the treatment of patients with hairy cells.